Welcome to day 3 of Brain Awareness Week for tonight's webinar on brain aneurysms, when to watch, when to treat, and why it's not always simple. So for those of you who are new or who don't know much about the Brain Foundation, I'd just like to briefly introduce us. The Brain Foundation was established in 1970, and our mission has 3 main goals. First is to fund high-quality Australian research into brain diseases, disorders, and injuries. Second is to provide medically reviewed resources to help people learn about those conditions. And lastly is to raise awareness about the impact of brain diseases and advocate for patients. And throughout Brain Awareness Week, we are highlighting some different resources. And tonight, I'd like to talk about how you can keep up to date with us, brain research, and brain health news after Brain Awareness Week ends. So if you're here, you've probably seen our emails this week, and we do send out occasional newsletters with updates about our work and research news. And if you've been forwarded the invite link, perhaps from a friend, you can sign up on our website. However, if you'd like more regular updates and you found the webinars this week informative, you can also find us on social media. We post lots of great content there, including our weekly Brain Teaser Tuesdays for those of you who love a challenge, a monthly neuro news update highlighting important and interesting new research, and other information about brain disorders and awareness events. So we'd love to have you there in the community, and if you're interested, you can follow us at the accounts shown on the slide. Just to make sure you're on the right place tonight, this webinar is for anyone who is interested in improving their brain health. If you want to learn more about neurological conditions, in particular for tonight, obviously aneurysm, and if you'd like to ask a question. Now I'd like to introduce tonight's speaker, Dr. Jorn van der Veken. Dr. van der Veken is an academic neurosurgeon working in Flinders Medical Centre and Royal Adelaide Hospital. He completed his neurosurgical training in Brussels, Belgium in 2018, then undertook subspecialty fellowships in cerebrovascular surgery at Macquarie University Hospital, the Royal Adelaide Hospital, and Flinders Medical Centre. And in 2024, he was awarded fellowship of the Australasian College of Surgeons. Dr. van der Veken has authored 28 peer-reviewed publications and is actively involved in international multi-center clinical trials. He's an expert in cerebrovascular surgery and is dedicated to improving patient-centered outcomes through his research and clinical practice. So we're really thrilled to have him here for tonight's webinar. And just a quick intro about me. My name is Anik, and I'll be hosting today's webinar. I'm the Programs and Impact Manager, so I oversee our research grants program and also write a lot of our website and newsletter content. And we also have Vanessa Mundell moderating the chat, and she's the fundraising manager here at the Brain Foundation. You can see her message that she's just sent now. If you have any questions or issues today, just ask in the chat, and Vanessa should be able to help. And without any further ado, I will let Dr. van der Veken begin the presentation.
Good morning, everyone. My name is Jorn van der Veken. I'm a cerebrovascular neurosurgeon working in Adelaide, in both the Royal Adelaide Hospital and Flinders Medical Centre. And I'm also a researcher investigating treatments of aneurysms, investigating the exact morbidity of the treatments that we offer patients and how to improve them, and which fits nicely in the theme of the Brain Awareness Week. So today I'll be talking about brain aneurysms, when to watch, when to treat, and why it's not always so simple. I don't have any conflicts of interest. So this is an overview of my talk. So I'll start by explaining a bit more what cerebral aneurysms are exactly, how do we get them, and if we find them, how do we manage them? And then I'll talk about some of the dilemmas that we often face in our practice. And then to round up, I'll shed some light on what the future holds, and how I'm hoping that the perfect worlds will look like in the next couple of years, and then some take-home messages. So to start, what are cerebral aneurysms? Well, aneurysm means dilatation or bulge. So it's a bulge of the arteries, so the blood vessels and the high pressure that deliver oxygen-rich blood to an organ. And when we talk about cerebral aneurysms, we're obviously talking about aneurysms on the arteries that go to the brain. We see them fairly commonly. We see them in about 2 to 3% of the population. And we're actually detecting them more and more, mainly because the threshold to offer imaging, as well as the quality of imaging, is constantly improving. Um, Aneurysms can rupture, and when they do, it's an absolute catastrophe. It comes with a high mortality and morbidity, but luckily that's still a rare event. Most commonly, we find these aneurysms incidentally. So people undergoing a scan for another reason after a trauma in context of headaches. And generally, they don't aneurysms don't cause symptoms unless in a couple of specific instances. But when they rupture, they cause predominantly a very, very severe headache, as often compared to a thunderclap headache, um, often followed by a patient who becomes more somnolent. And on one of the pictures here, you can see the bulge on a garden hose, and that's what I often compare it to. It's this we can spot this bulge on one of the vessels on a high pressure. This is an overview of the arteries going into the brain, and you can see the similarities with the picture of the old oak that I just showed as well, where the all the arteries branch off to different areas in the brain, and some of the more common locations for an aneurysm to arise is the anterior communicating artery, which you see here sitting just underneath the frontal lobe, the middle cerebral artery, and the posterior communicating artery as some of the more frequent locations. And here on the right, you can see the bulge on the middle cerebral artery. It's an intraoperative picture, and you can see how it bulges out. It has this cherry-like appearance. Now, what are some of the risk factors that contribute to aneurysm formation? Well, we generally divide them in modifiable risk factors, so risk factors that you can change. Smoking is by far the most important one. It significantly increases the risk of developing aneurysms, and arterial hypertension or a high blood pressure is also a very important one. Um, Apart from that, there's a non-modifiable risk factors. So the risk factors that unfortunately you can't change. And age is a common one. So the older you get, the more likely it is to develop an aneurysm. The typical age at which we diagnose aneurysms is between 50 and 60 years old. Sex, so females are more likely to develop an aneurysm. So there's likely a genetic and a hormonal component contributing to it as well. And then a family history, if you have a first-line family member who had an aneurysm in the brain, not an aneurysm elsewhere in the body, but an aneurysm in the brain, and particularly an aneurysm that has ruptured, the risk of developing or having an aneurysm is also elevated. And then there's some rarer genetic or connective tissue disorders like polycystic kidney disease, Marfan's disease, Lewy-Dietz syndrome, and also as you could see on the picture with of the old oak tree, there's a lot of variety in how arteries in the brain twist and turn, and some of these vascular variants or those specific twists and turns contribute to developing aneurysms as well. Um, Now, what do we do when we find an aneurysm incidentally? So you have a patient, she had a fall, she underwent a scan, and it was suspicious of an aneurysm, which was then confirmed on a more dedicated scan. Well, when we see a patient, we generally have a couple of different options. We either decide um, to keep a close eye on it and see if this aneurysm start changing, or if it's a very suspicious looking aneurysm, an aneurysm that we think might rupture, we might decide to treat it. Or, for instance, if it's a very tiny little aneurysm in a patient who has a lot of other medical comorbidities or issues going on, we might even decide to discharge a patient and just forget about it. So, what are the factors then that we take into account on what we need to do with that aneurysm? Well, it basically comes down to trying to estimate the natural history, or more specifically, the risk of this aneurysm rupturing in a patient's lifetime versus the risk of treatment. Evidently, if the risk of treatment would be zero, we would be treating all aneurysms, but that's definitely not the case. So looking a bit more into detail, well, what are those factors that might decide whether an aneurysm might rupture or not? Well, again, there's a whole bunch of different factors that we take into account. We look at the aneurysm specifically, mainly the size. Generally, the bigger the aneurysm, the more dangerous the aneurysm is. The morphology, is it nice and smooth, or is it irregular with a lot of bleps on it? The location, we know that some arteries or locations in the brain are more prone to rupturing. And then growth, that's a very important one. Although an aneurysm might initially look very, very benign, if we see that it starts to change over time, that is often a sign that the aneurysm is unstable and that it might rupture. And that's often a strong indicator for us to recommend treatments. But obviously, you never just look at the aneurysm by itself. You also look at the patient who harbors the aneurysm. Um, you look at them holistically and see, are they still fit and healthy, and what are some of the risk factors for rupturing that patient specifically has? And again, similar risk factors to the risk factors that cause an aneurysm to form. Well, a lot of those risk factors also play a role in the rupture risk. So again, smoking, a high blood pressure, being female, ethnicity, again, confirming that there is a genetic component to it. We know that Finnish and Japanese people have a higher risk of developing an aneurysms and having an aneurysm rupture. And then having a history of a previous rupture. So if you had a rupture in the past and you have another aneurysm, that aneurysm is more likely of rupturing as well in the future. So once we've taken all these factors into account and we think or assume that this is an aneurysm that is going to cause problems over a patient's lifetime, we might decide to treat the aneurysm. And traditionally, this was all done through a small opening in the skull, and then putting a metal clip around the neck of the aneurysm. So as such, preventing that blood flows in that bulge, and as such, the aneurysm can no longer rupture. But then in the early 90s, a different technique was developed where they actually treat the aneurysm from within inside the blood vessel. So instead of making an opening in the skull and trying to put some clips on the outside, what they do is they puncture an artery at a distant location, so typically the wrist or the groin. And then they go up with a catheter and insert a couple of little metal coils in within this aneurysm sac. The aneurysm thromboses and is no longer at risk of rupturing. And the last few years, some other devices have been developed that allow treating a whole range of other aneurysms, such as stents have been developed, flow disruptors, flow diverters, and which again allows to treat a whole different range of aneurysms in different locations. And that's what we're seeing worldwide, is that a lot more aneurysms are being treated. And again, coming back to that balance where you balance the treatment risk versus the natural history, evidently the less invasive or the safer your aneurysm treatment is, the lower the threshold to offer treatment. And that is what we assume is likely driving the reason why more and more aneurysms are being treated. And you can see it here. This is data from Australia, where the blue line represents treatment through endovascular means and the red line treatments through surgery. And you can see that both in public and in private, endovascular treatment is becoming more and more common. And that's a trend that we're seeing worldwide. Now, what are some of the dilemmas that we're dealing with as neurosurgeons or as interventional neuroradiologists when we have a patient with an aneurysm? So the goal of our treatment fundamentally is to prevent morbidity. We know that if an aneurysm ruptures, it causes a significant amount of morbidity and comes with a high mortality. So that's what you want to prevent from happening. But you need to be able to do it in a way that you can still assure a good quality of life. There is no point in fixing an aneurysm to prevent it from rupturing, but then at the same time cause a big stroke or cause a lot of morbidity that takes away the quality of life of your patients. Um, and that is so important to emphasize. And this is a fictive clinical case, but it's a scenario that we not uncommonly encounter in our practice. So this was a 62-year-old female accountant. She was an ex-smoker, had controlled blood pressure, no family history, but was complaining of headaches, underwent a scan, and it shows an incidental finding of this ugly, irregular looking anterior communicating artery aneurysm. She was discussed in our multidisciplinary team meeting, and the unanimous recommendation was to treat it. It was a large aneurysm, it was irregular. Um, it ticked all the boxes of an aneurysm that was likely to cause trouble in the near future. So the first question to answer is, does it need treatment? Unanimously, the answer was yes. And then secondly, which treatment modality? Well, decided to treat it through endovascular means, and she underwent coiling. So procedure went fine. Post-op day one, she was discharged. At 6 weeks, she was seen in clinic. On the surface, everything looked perfectly fine. She says she didn't have any complaints. She was managing all her daily activities, and she wanted to return to work full time, which we agreed on. We saw her again in that 3 months follow-up where she mentioned that actually she was struggling at work, mainly with multitasking, with managing the complex finances. Her partner mentioned some mood changes and irritability, and there was also some increased fatigue and reduced social engagements. As we typically do, we got her an MRI, which showed that everything looked perfectly fine. Nonetheless, we had her tested extensively neuropsychologically, and that showed that there was an impaired executive functioning. So the part of the brain that is involved with achieving goals and is one of the higher cognitive functions. Furthermore, there was some slower processing speed and some subtle memory deficits. And despite us offering her strategies to improve those deficits, she decided to retire early after 12 months because work had become too difficult for her and a source of distress. So, what does this highlight? Well, a couple of things. Firstly, the models that we use to predict the rupture risk, they're based on large population databases. So it gives you an average. It does not give you the exact day. It does not give you the exact number for that specific patient in front of you. That will undoubtedly be slightly different than the patient that was included in those large databases. Furthermore, although we generally try to simplify the complex decision to balancing the treatment risk that you run during exactly that procedure, and you balance that against a lifetime rupture risk. Again, the rupture risk that we predict is often estimated over the next 5 years and then extrapolated over a patient's lifetime. It doesn't give you the exact day, and um, it is a constant struggle because as I showed with the clinical example, the treatment risk often comes with some form of morbidity, and most of the time patients wake up well without any deficits. But if you have a patient that you have created a deficit, you've potentially taken away some of their quality of life, and that is yeah, that can be a very frustrating process for both the patient, evidently, as well as the treating doctor. And then another dilemma is the timing of treatments. If we would know in an ideal world, okay, well, the aneurysm is likely to rupture during that week, we would tailor our treatments to having it done just the week before the rupture risk. With that approach, you would minimize the time that those patients are exposed um, to the possible complications of their treatments, and you've maximized the qualitative life. And what does that imply, the above? Well, we have an imperfect rupture prediction model. It is still hard to estimate the exact morbidity risk, and that means that we're treating some patients that probably shouldn't have been treated, but also from time to time we will have a patient that we think um, that they're better off without treatment that end up presenting with a rupture. So that happens as well. And then there's the ongoing debate whether all aneurysms should be coiled or whether we should be clipping more. This question about the durability of the endovascular treatments. And then there's a technology versus evidence gap. A lot of these new devices have been brought on the market, but we don't have the same experience as we have with clipping. So it's hard to know what the long-term results will be of some of these newer devices. And finally, well, does the patient who goes to sleep, does he wake up the same? And that's the area where I'm doing my research. As I said, the ultimate goal is that you exclude the aneurysm, but that it doesn't come at a cost of any neuro or neurocognitive deficit. And we still haven't mapped out 100% the morbidity of our preventative treatments. So, how does the ideal world look like then? Well, as I was already alluding to on my previous slides, in an ideal world, we would know exactly when an aneurysm is about to rupture, and at the moment, it's still a rough estimate, but we are getting better at it, and particularly with AI, we now have computational fluid dynamics. We have vessel wall imaging, and what that shows is, for instance, vessel wall imaging. It shows whether an aneurysm is stable or whether an aneurysm is unstable. If an aneurysm is stable, we know that we don't need to jump to treating it, that we can continue monitoring it. Um, Whereas if it's unstable, we know that there's likely an increased risk for rupturing. Computational fluid dynamics shows the areas of the aneurysm that are weaker and that are more prone to rupturing. So although it's still early days, I'm hoping that in the next few years this will become more routine part of our practice, and that we can estimate better which aneurysms are likely to cause problems. And then again, estimating the exact morbidity of in each individual patient, I would say, well, that's again what we're doing research on. Ideally, you can also identify which patient is more at risk of developing morbidities due to their treatments. For instance, we know that when you treat an aneurysm endovascularly, we commonly see tiny little microinfarcts on the post-op scan. We call them silent brains infarcts, but there's more and more data coming that it might actually not be so silent as we think. And then if you can predict which aneurysms are likely to rupture, well, maybe there's a role for to reverse the rupture risk, and that is another study that is going on. That's a multi-center study going on in Europe at the moment, where based on vessel wall imaging, they see which aneurysm is unstable, and then they're trying to reverse that by giving specific anti-inflammatory medication. And I think that's particularly a very promising tool. Maybe we can come to a situation where we actually no longer need to treat aneurysms either with surgery or with coiling, that we can give medication and as such prevent aneurysms to rupture. But that's still very, very early days. Um, it's a space we need to watch closely. So just to finish up, some take-home messages. Cerebral aneurysms, we see them very commonly. We diagnose them more and more, and as such, we're treating also more and more. On top of the fact that we assume that our treatments are becoming safer and safer. But there is still quite a bit of uncertainty in estimating accurately the rupture risk. That's an area that we need to continue to improve. And also mapping out the morbidity of the treatments. The treatment success goes beyond the angiographic success. We want a patient that is exactly the same, who wakes up exactly the same as the way he went to sleep. But luckily, we're getting better and better, both in terms of um, predicting the exact rupture risk, as well as mapping out the morbidity of our treatment, and as such improving the patient selection. Um, and that's it. So thanks for your time. I do want to thank the Brain Foundation and the NRF, who are funding one of the projects that we're doing at the moment in assessing the neurocognitive outcomes of electively treated aneurysms. Thanks for your time.
Hello, Dr. Van der Veken. Thank you so much for that fantastic presentation. That was so informative, and we're really excited to get into the Q&A segment now. For everyone who hasn't submitted their question yet, there's still time. We'll keep refreshing the Q&A throughout, and also keep voting for the questions that you'd most like to see answered, so that yeah, we can prioritize the ones that are most popular. So the first question that we have, Dr. Van der Veken, is from Bronwyn, asking if there is an association between migraine and aneurysm.
Yeah, it's an interesting question, and it's one that patients often ask, and I can see where it comes from. Both aneurysms and as well as migraines involve the blood vessels, as well as often present with headaches. But we've done many studies on that, and we haven't found a clear correlation. Migraines are fairly commonly, so a lot of people do get a scan for migraines to make sure that there's definitely nothing underlying. And as I explained in my talk, aneurysms, we're seeing them more and more, mainly because the imaging is getting more sensitive. But migraines is not a manifestation of a brain aneurysm, and migraines don't cause brain aneurysms to form. What I do want to emphasize is that if you are known with migraines and suddenly you have a very different type of headaches, a very sudden severe sharp pain, then it might be worthwhile getting an urgent scan. But to answer to the question, no, there's no correlation. Yeah.
Wonderful, thank you. The next question that we have is from Caroline, who has asked, given that cerebral aneurysms are more common in 50 to 60-year-olds, is there any evidence for HRT in postmenopausal women in helping to prevent the progression of an aneurysm, or preventing the development of new aneurysms?
That's a very difficult question. Firstly, the role of hormones in the development of aneurysms, it's not super robust data. The data, I mean, we clearly do see an association, but how it exactly forms or contributes, it's not a simple A plus B equals C. It clearly plays a role in a very complex cascade. The bit of evidence that we have comes mainly from animal models I remember a study on mice where they removed the ovaries and then saw that the endothelium of the blood vessels had changed, and then it became more less elastic, and that it could contribute in that sense to aneurysms. But it's definitely not an influencing factor that is strong enough to consider giving hormonal replacement therapy. And there's also risks with hormonal replacement therapies in other areas. There's now research happening in how this might actually contribute to the formation of, for instance, meningioma. So I think it's a very interesting area, a very good and difficult question, but I think at this point, yeah, it's a bit early. I wouldn't be surprised if we see more data on this appear in the near future. But for now, definitely not a recommendation to start hormonal replacement therapy in an attempt to try and prevent aneurysms. No.
Hmm. Okay. Fantastic. Thank you for that answer. Definitely looking forward to seeing what more comes out about that potential future research. The next question that we have actually relates to your research.
All
Um,
right.
and I know that you discussed it briefly, but if you wanted to elaborate a bit more, um, Caroline has asked if there is any research regarding the long-term cognitive impacts of either ruptured or unruptured aneurysms, including their treatments. And
Yeah.
yeah, I guess if we wanted to discuss a bit more
Yeah.
about where the research is at there.
Yeah, I'll try not to start a tangential talk for 60 minutes on how important it is. But yes, there is research, but definitely not enough research. So there's more data on ruptured aneurysms, how that impacts cognitive function. The moment you have a rupture, the brain function is no longer the same, and you will have some impairments depending on how extensive and a lot of other factors, how extensive the bleeding was, might all influence how severe that deficit will be. But what I think is more important and more pertinent is the research for unruptured aneurysms. I mean, these are patients that are fundamentally asymptomatic, and we need to keep them that way. And we don't have a clear answer on what the effects are on the long term, and then I'm talking about 20 years down the track. Um, what surgery or what endovascular treatments do. We know from studies that with every tiny little infarct that you have in the brain, you do increase the risk of having cognitive problems down the track. And as I mentioned in my talk, we commonly see them either after surgery or after endovascular treatments, but nobody has really thoroughly investigated the effects. Like most studies always look at a couple of years after treatments, but we don't have a good understanding how that accumulates potentially a few decades down the track. So yeah, very good question, and a very important area, and an area that we're trying to yeah, get a bit more knowledge on. Yeah.
Wonderful. Well, hopefully the results of your research can at least start to shine more of a light there.
Yeah.
Um, and the next question that we have is from Robin, who's asked, what is the mechanism by which aspirin prevents or decreases the risk of aneurysms?
Yeah, very exciting area. So as I shortly alluded to in the talk, we always imagine an aneurysm rupturing being a little balloon that suddenly bursts and it being driven by a purely physical or mechanical factor. You have a little blip and you press it and it ruptures, but actually it's more of an inflammatory process. It becomes a wall that's very unstable and then suddenly bursts open. So it's mainly an inflammatory process. And aspirin has an anti-inflammatory function. There's some other drugs that have that as well. And we have some data, radiological animal studies. We're starting to get more population data on that as well. That it stabilizes the inflammation. I think that is a very, very exciting part. And the study that I mentioned, the Protect-U study, is now a study in Europe that's been running since a couple of years, multi-center trial where patients who have an aneurysm, they undergo a very specific scan to estimate the amount of inflammation that they have in the aneurysm wall. Then they will give them anti-inflammatories, um, aspirin being one of them, and then they will see if that truly reduces the risk of rupture. And yeah, I think that's where the future of aneurysm treatments will lie. I don't think it's a discussion about coiling versus clipping. I think it will be a matter of picking up the unstable ones and turning them into stable aneurysms so that they don't need treatment. But we're still, unfortunately, many years away from that. Yeah, but very, very good question.
That's fascinating. That's so exciting to hear about yeah, that kind of work. The next question that we have is from Mary, who has experienced a ruptured brain aneurysm. And like many people, she is still experiencing a lot of those cognitive changes that you talked about. I know that we can't provide personalized recommendations here, but do you have any suggestions for people in general about how to approach those executive function changes and like how to organize better after those deficits?
Yeah, I unfortunately come across many of these patients who struggle with this, not just in vascular neurosurgery, but also in oncology. It's um, the brain functions in a we traditionally have the image of the brain being this area does this and this area does that, but we now know that the whole brain is constantly all the areas of the brain are constantly in communication with each other. So we need to see the brain more as a network of very important pathways that are constantly in communication with each other. And there are some areas that are more susceptible or more sensitive to causing cognitive deficits. Depending on which area is involved, you might be able to train it more specifically. I think to answer her question specifically, um, it's hard. You can compensate to some extent by training and by stimulating the brain in many different ways. Reading, intellectually challenging it. If you have a weakness, by touching, by all these different stimuli that come to the brain might help in try and reconnect some of those networks. But there's a limit to what's possible, and I'm hoping that one day we will either be able to regrow damaged brain, or there's now studies happening where we're stimulating certain areas of the brain with magnets or with ultrasound and try and improve those networks. But it's still very early days. I think at this stage, stimulating your brain in a very large variety of ways, and potentially getting help from a neuropsychologist to identify which areas in particular are affected, and then getting specific exercises might help. But I know it's unfortunately there's no simple fix, and there's a limit to what to yeah to what a patient can recover. Yeah.
Mm, mm. Okay, thank you for that answer. The next question that we have is if you can please explain the general differences between an aneurysm and a stroke. It's something that I'm sure many of us have heard before. I've heard people say time and time again, "Oh, I'm having an aneurysm," and
Yeah.
they are different things. So can you please talk about that?
Yeah, it is a bit confusing, and we not uncommonly use them interchangeably. So stroke typically, so stroke, we have two types of stroke. So stroke means that a certain area of the brain at some point is no longer getting adequate blood supply, and in the majority of the time, that's because a little artery is, or a bigger artery is blocked. So you've got a clot in within your blood vessel, and so that prevents blood from arriving in a specific area of the brain. Again, depending on the function of that area, that might present in a different way. So we call that an ischemic stroke, or a stroke because of a thrombus, or a vessel occlusion. Now, a small subset of strokes can be because there's a sudden bleed, like if you have a sudden catastrophic bleed within the brain, that also prevents a certain area of the brain of not working properly. So an aneurysm is one of the many causes for a brain bleed, and can cause a stroke. But aneurysm and stroke, they are different entities. So to summarize, a stroke means a certain part of the brain is not getting adequate blood flow. Most of the time is because the blood vessel occludes, but it can sometimes also happen because the blood vessel tears open. And an aneurysm, or a bulge on the blood vessel, is one of those factors that can cause that. I hope I didn't make it more confusing, but yeah.
I think it was a fantastic explanation, so I hope everyone else found that helpful as well. It can be quite confusing sometimes for sure. The next question that we have is from Bronwyn asking if there's any tips on lifestyle prevention strategies other than not smoking. Yeah, there any research into that?
Yeah, definitely. Unfortunately, it's all the boring stuff in life. So meaning eating healthy, having not exaggerating with alcohol, trying to prevent having too much stress. It's the sort of typical advice you get, but again, stress does affect inflammation, and that happens on every level, also on the level of blood vessels. Yeah, all the typical stuff, regular exercise. Again, aneurysm formation is an inflammatory problem. So although we don't have robust evidence to suggest that unhealthy food directly contributes, it seems logical that the radicals that you have when smoking, they can also occur when eating unhealthy foods, that they can contribute. Yeah, it's for all organs in the body. This advice is yeah stands.
Mm. Yeah, it's something that we've actually heard in the other two presentations this week as well. Heart health is brain health. I think both speakers
Yeah,
have said exactly those words.
yeah,
So, even if it does sound boring, it can address lots of different conditions. So it's definitely worth
yeah.
investing the time in. The next question that we have is from Liz asking if an aneurysm can't be located, What risk is there of reoccurrence or yeah, potential health issues?
Well, it's a bit of a difficult question. I mean, we sometimes end up in situations where there's a bleed that looks very, very suspicious for an aneurysmal bleed, but you do a scan, you can't see anything. You do an angiogram, you still can't see anything. You do an MRI of the whole brain and spine. You do another angiogram. You keep looking for it, and you can't find the aneurysm. Well, then yeah, at some point you need to conclude that there isn't an aneurysm, and there are some other rarer diseases that can sometimes manifest as a ruptured brain aneurysm, and then you kind of need to come to that conclusion that's likely the underlying cause, and we often still get a delayed scan just to be sure that there definitely nothing appears in a delayed fashion. But most of the time, it's extremely rare that we do pick up something delayed. And if the patient doesn't have any risk factors and all the imaging shows that there's no aneurysm, then well, I think the only logical thing to conclude is that there wasn't an aneurysm, and these patients don't necessarily need follow-up. It's different if you have a patient who has a very strong family history. In those patients, we do recommend lifelong monitoring with a scan every 5 years to look for aneurysms. Same with patients with some of those rarer connective tissue disorders. We generally do recommend screening them as well every couple of years. But those are very, very specific and particular scenarios.
Mhm. Great, thank you. The next question that we have is from Swara, asking what kind of precautions or restrictions can someone take if they have an aneurysm and they decided not to have treatment?
For exercise precautions, I don't think there are any. Um, yeah, it's yeah, for exercise precautions, I wouldn't recommend any. Lifestyle changes. Very, very important to not start smoking. Make sure that your blood pressure is well controlled, etc. But I think that's a question that needs to be addressed on a case by case. As I said, it's always when you have a patient, there's so many different factors that you take into account. And sometimes it happens that you've got actually a complex aneurysm that you think, well, this is at risk of causing a rupture in the future, but the treatment risk is just thought to be so high that you actually decide, well, we're not going to do anything about this. And in those scenarios, yeah, perfect blood pressure control, no smoking. Um, Likely in the future, that will also involve including some form of anti-inflammatories, but again, at this point, it's not enough robust data. But for exercises, generally, there's no evidence to suggest that contact sports increase the risk. There's always a couple of exceptions. I think yeah that's something to discuss with your treating vascular neurosurgeon, but generally, there's not really any exercise restrictions. Yeah.
Mm, okay. Wonderful, thank you. The next question from Andrew is asking, is there a specific size of aneurysm that's likely to be a problem, or does that vary?
Ho- Back in the 90s, there was the 7 millimeter cutoff. They used to say below 7 millimeters, aneurysms don't rupture. That was a conclusion based on not the best data. If you look, so 7 millimeters is still a size that circulates, particularly in the older generation. If you actually look at the majority of aneurysms that present with a rupture, they're actually the majority is just below 7 millimeters. So that 7 millimeter cutoff is it's I think is completely outdated. Size definitely does play a role, But I think what is more important is how an aneurysm looks like and the vessel from which originates. Even today, I had a ruptured aneurysm I needed to treat in emergency, and it was 3 millimeters, but it was very irregular. And yeah, not surprisingly, the patient was a very active smoker. Um, so again, we do put more emphasis on other factors than size. Generally, overall rule, large aneurysms, yeah, definitely come with increased risk, but it doesn't mean because an aneurysm is small that it can't cause problems. It's definitely not the case. Yeah.
Mm, great, thank you. The next question that we have is if it's possible to have an aneurysm rupture and then to continue going along with your day, like for an unchecked period of time. We often hear that when an aneurysm ruptures, that it's, a catastrophic event and you go straight to the hospital. But is there a chance that people can kind of go about their day and not have it treated?
Yeah, yeah, it does happen. It's definitely rare, but it happens. People presenting in a delayed fashion, sometimes with spasm because the vessels respond to the blood around it. That happens. It also happens that you treat an aneurysm that was thought to be purely elective, but then when you see it during surgery, you can see that there's been clear signs of bleed, of an earlier bleed that happens, but it's definitely a more uncommon scenario.
Mm,
That's what makes medicine interesting. I guess it's yeah, there's always outliers, there's always people behaving very differently. Yeah.
mm. Great, thank you. The next question is I know that we discussed this briefly in the presentation, but are brain aneurysms similar in risk to other aneurysms in the body? And especially in terms of family history, or even history with your own personal medical history?
Um, there's a lot of overlap in the sense of risk factors. There's a lot of overlap in how the aneurysms look. Histology. So if you look at the tissues, if you see which parts of the blood vessel are affected, there's similarities too. But what is different is that the presence of having an aneurysm in your aorta or in your lower extremities is not gonna influence the rupture risk of the aneurysm in the brain, or it's definitely not something that we take into account in our decision making. Um, so yes, there are some similarities, but in the end they are very different. Yeah, they have a very different management, and they don't influence each other in terms of needing intervention. Yeah.
Mm. Okay, thank you. The next question that we have is from Marion asking if there's any problems with aneurysms and epilepsy.
Um, that's a question that can be answered in many ways. So I assume she wants to know that if you have an aneurysm and you have seizures, whether that increases the risk. Not necessarily. But some aneurysms, particularly when they're larger, they can cause brain irritation and as such be a cause of seizures. We can also see seizures after an aneurysm is treated because of the surgeon irritating the brain, or some of the metal clips irritating the brain, or if there's been a rupture, it happens that the patient afterwards develops seizures as well, because again the brain has been damaged. But overall, having seizures and an aneurysm, it's not something, if it's a normal aneurysm, it's not a factor that we would take into account to lower our thresholds to offer surgery or treat or endovascular treatments. No.
Great, thank you. The next question is from Heidi, and I think we've answered the first half of this about the relationship between brain aneurysms, and she's asked about aortic aneurysms, but in general, aneurysms in other parts of the body. But she's also asked if you collaborate with cardiovascular scientists to help inform your research.
No, I've got a good friend who's a cardiothoracic surgeon who I'm seeing in a couple of weeks. I'm sure it will definitely talk about aneurysms, and I might this question might stimulate me to maybe dive into that area a bit deeper. Um, I don't work or do research with cardiovascular scientists. We work with engineers, we work with neurologists, we work with fundamental researchers. But yeah, we have a very big team. But there's no cardiovascular scientist. But yeah, it's good. Sometimes the best ideas you hear when you're actually talking with people outside of your niche. I was at just a little sidetrack. I was at a computational neurosurgery conference a couple of weeks ago. I mean, I'm still struggling with using Excel and PowerPoint, but I got dragged into it because a friend of mine was talking there, and it was actually an incredibly stimulating conference, and I definitely see the role now of including more AI in doing research. So no, it's a good suggestion. I might, yeah, as I said, I might bring up aneurysms with him and see if there's any good ideas that come from it. Yeah.
Mm. No, it's definitely always great to continue exploring. We'll try and get one more question in the before 8 p.m. This next one is from Tanya asking if you can reduce the risk of aneurysms or future aneurysms by reducing brain inflammation, and if so, what can decrease inflammation? I know we talked about aspirin, but are there other strategies?
Yeah, again, coming back to lifestyle, I think healthy food, no smoking, hypertension, they're all so important. Stress levels very hard in 2026, where everybody is constantly running out of time. Um, there is some data on blueberries and fruits, the anti-inflammatory effects of that. Would be an incredibly difficult study to perform to see if that truly reduces. I think there's a lot of common sense in it. I don't see the harm in taking up lifestyle changes that reduce stress and inflammation in general. But if you would want to have really strong, robust data on that, as I said, it would be an incredibly difficult study to perform. And I don't think we'll ever be able. Maybe AI might be able to pick that up on very large population data, but no.
Well, thank you so much. Know you've had a big day with work and patients and everything, so we'll let you go. But thank you so much for your time this evening
Yeah.
and such a fantastic presentation and Q&A. I know I've learned a lot, so oh, sorry. I know I've learned a lot, so I hope everyone else has too. Um, I hope we'll see you for our presentation, our webinar tomorrow on alcohol and brain health. But until then, thank you so much, Dr. Van der Veken, and have a lovely night.
No, you're welcome. Thanks for the opportunity, and yeah, I hope I could give some useful information, and yeah, have a good evening, everyone. Bye.
Thank you. Bye.